Spring into summer by looking younger. Call Vein Clinics of Hawaii to schedule your free consultation today. Facial and body rejuvenation procedures are designed to help you look and feel your best without breaking your budget. Reduce pigmentation, fine lines, wrinkles, scarring, and stretch marks with minimal invasiveness or side effects. Confused about which procedure is right for you? Call 427-5565 to schedule an appointment or visit veinclinicsofhawaii.com.
Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Yep, it is the radio show about your veins, about your circulatory system, about all of that stuff. Pretty important stuff. So goes your circulation, so goes your legs, so goes your mobility and your quality of life and all of these other questions that come up and answers, more importantly, that were given by Dr. Juliff and the trained folks at Vein Clinics of Hawaii. Like the guy was just saying, there's 4 of them. Big Island, Kauai, Maui, and here on Oahu, where we record this show, and we certainly invite you at any time to contact either the office in the town that you're in on your island, or just go right to the website and communicate with us. Find out where to click on things. There's a myriad of information that keeps changing there, and it's not just veins. There's a lot of other really neat things to do if you're going to be in town and at the clinic. Well, that being said, when I found out, Dr. Juliff, that today we're going to talk about spider veins and reticular veins, I happen to know that I've had troubles in each area. And sometimes, if not all the times, the reticular veins that I've had treated are part of a treatment process that my insurance pays for. And the spider veins that I've had looked at are part of my desire to look super svelte and sexy in my old age. It's a decision that I make, and I want to talk specifically about one spider vein here in a minute. But it is something that, for whatever the reason, is not covered by insurance. And I want to make sure that we cover those things first. But I'll tell you one thing. It really did have to do with self-esteem. On my left leg, above my knee, and below my waist, there was this large spider vein. Big thing, And I always thought that it was there because of a trauma, because I got hit by a softball or something, It really wasn't. It was just this big spider vein.
Yeah.
And it was one of the first things that I had treated. And there is no trace of where it was. And it was something that I was conscious about, self-conscious.
Yeah.
I used to wear Bermuda shorts fishing instead of everybody else wearing shorts. I'm wearing long johns because I didn't want people to see that ugly knee.
Yeah. Most people think that it's just women that come in, especially for the cosmetic stuff, and want that injected and taken care of. But we have plenty of men, just in general, who are patients. But we have plenty of men also who are coming in for cosmetic reasons, and why not? Men want to look good too, but. We see a lot of people with spider veins, and so the question always is, is this a part? Is this a part of the picture of venous insufficiency just in general, or is it just sporadic spider veins? Half the time it is, half the time it isn't.
Yeah, I want to work on that a little bit today, time permitting. And then the other thing is that, and I think it's very interesting because at the same time I had that big thing on my left thigh. I had on my right lower leg a big old thing that was sticking out, but I didn't know it was there. Right? I never saw it.
Yeah,
it was, and I think it was a grandkid that said, "Hey, Papa, what's that? Does that hurt?" And he touched it. I said, "No, it doesn't hurt, but I don't like it.
It looks ugly.
I don't have that anymore either."
Yeah.
But I mean, seriously, I do know that people make a conscious decision to do that, and I'm happy with it. I mean, if anybody's self-esteem is up, or they'll wear a pair of shorts instead of a pair of long jeans at the beach, more power to them.
Yeah, sure. And there's many people in professions that, need it,
absolutely,
quite frankly.
Absolutely, So, especially in Hawaii, where we're not exactly overlayering our clothing.
Yeah, right, sure.
Okay, so but how we connect the two, spider veins and reticular veins, I'm not even sure people really know what what difference there are. What's the difference?
Yeah. Well, you know, the like I said, the question is always, you know, is it part of a picture of venous insufficiency? And we've got this classification system for vein disease. It goes from C1 to C6, having to do with the class. Mm-hmm. And C1 is the least, C6 is the worst, and C6 are, you know, people that have, you know, bad skin problems, ulceration, etc. And that's always, of course, a medical problem. Spider veins in general are considered, well, they're C1. They're the first, you know, the lowest, I guess, urgency with respect to it possibly being a sign of venous insufficiency. And they're always, unfortunately, by the insurance companies, considered purely cosmetic.
You know what? I'm really glad we started off with that. And here's the thing that I think is important. When I first found out about this classes, 6 classes, they're not exactly broken up in 6 equal parts. You know, but what I find myself grateful for is that I know where I am on the chart. Mm-hmm. I mean, it's a bell curve, right? It's from no venous problems to big hole ulcers, and the more you can get done before it gets too high up the chain, the better off. In other words, if you can slow the process or manage the process, that's the goal, isn't it?
It is. And as you go up on that scale, then the urgency of getting it treated it goes higher and higher. But that's absolutely right. There's any number of patients that we could have altered their course had they been treated at an earlier stage. No question about that.
And by the way, and this is the ironic thing, you know, in other parts of medicine and other parts of insurance, some of the insurance companies are realizing treating something early is advisable.
Right.
And here is automatically, if you're up the food chain on these 6, your insurance is going to cover you. The worse it gets, it seems like the insurance is happier to cover you.
They are. And sometimes it's unfortunate because, you know, we could save the healthcare system a lot of dollars if we treat people earlier and don't allow them to get to that ulcer stage. But unfortunately, insurance never covers a spider vein, the treatment of spider veins. But it's always been a question in my mind as to, do spider veins cause symptoms?
Yep.
And sometimes we have people coming in and saying, "Oh yeah, you know, I've got pain right here," and they're pointing to, you know, a big complex of spider veins. Now, you never know, because sometimes people are trying to make the case for insurance covering.
By the way, not only the doctors know about this, but the patients know about this too, right?
Yeah, exactly. So it's a little hard to sort out sometimes. But it just seems like in some cases, people actually do have symptoms from spider veins. Now, again, that's not going to change the mind of the insurance company because they think it's purely cosmetic. But it helps us kind of, you know, define how much, any particular thing may be interfering with a patient's quality of life or daily activity.
Okay, I got one for you. You know, we've been talking in different times, and it's talked about on the streets every day, the huge opioid dependence we have in this country over medication. And I'm wondering if sometimes people make a claim that they have these symptoms for spider veins, and they do, and they start medicating for it. Because, I mean, if it's not covered by insurance, that means unless you can afford to have the surgery, you might say, well, I can't have the surgery, but I can sure take this whiz-bomb pill. Yeah. You know?
Anything that's going to cause pain, especially chronic pain, that's going to heighten the interest in, illegal or, medications that should not be being used chronically. Sure.
So here's the question. Does the insurance company, let's say that you prescribe a pain medication for me because I've got pain. So a certain level of venous disease, obviously the insurance company say, well, the doc is working on this and there's pain involved, so he's getting pain meds. But why not all the way down at the bottom? I'm guessing that they would still deny you pain medication for spider veins.
Yeah, they're going to deny anything for spider veins.
Just thought I'd throw it out there.
Yeah, typically we try not to treat people too much with pain medications because there are the other non-opioid kind of medications that can be very, very helpful. And we want to treat that patient and take the cause away. So, we try to stay away from, prescribing pain medication specifically. But so with respect to the different, I thought I would just kind of, we'd talk about the different types of veins. There's spider veins, of course, but, spider veins and varicose veins and reticular veins, how are they similar? How are they different? Well, starting out with varicose veins, obviously, varicose veins are larger. Everybody knows that. They have a ropey kind of appearance. They're usually elevated. When you can rub your hand over a varicose vein and kind of feel that elevated area, which is the vein.
Well, that's one thing if you can feel it. But now it's also, depending on some people and how bad it is, it's visibly very noticeable, not just by them, but by others.
Sure. Definitely. Most varicose veins are visual. Yeah. You can see them. Of course, most spider veins are visual too. But the varicose vein resides or is present anatomically at a little deeper level than spider veins. Varicose veins are below the level of the skin. They're in what we would refer to as the subcutaneous tissue. So they're a little deeper. So when they become dilated, they can cause symptoms. We know that, and that's kind of a recognized process. So as they fill with blood, they can create throbbing pain, discomfort, etc. They are usually associated with this process of venous insufficiency, which means that the deeper veins are not functioning properly. So almost all of the time, although there are situations where we see people with varicose veins and we don't find that venous reflux or venous insufficiency, but by and large, varicose veins are a very strong sign of chronic venous insufficiency.
Okay, now there's always a concern by saying, well, you remove veins, right? You take a vein that's sick and you take it out of there. Is there a limit? How many times can you go to that well? How many veins can you take out of this leg of mine before either you get them all or they stop being varicose?
Well, with respect to varicose veins, the varicose veins that arise, and unfortunately, since venous insufficiency is a genetic problem, that people can have recurrent varicose veins, but varicose veins serve no purpose whatsoever.
Okay, now, let's make sure that, this is really important, because varicose veins, hasn't your system figured out a way to circumvent whatever they were doing?
Well, varicose...
Or parts of it anyway.
Yeah, varicose veins are veins that were there before. It's just that now, because of venous insufficiency, abnormal blood flow, increase in pressure within the venous system, they become dilated and abnormal. So they were there before, but they were a lot smaller.
Okay.
And again, are they serving any?
Are they being used?
Are they serving some significant purpose with respect to your circulation? No, none whatsoever. So. Do we feel like there's a limited number of varicose veins that we can take out of somebody's leg at any one time, or even in a repetitive fashion? In general, no.
Yeah, no, that's good.
Now, as you do those procedures more and more, it becomes a little more difficult to get sort of a complete result. But in general, no, we can do that as much as as much as the patient needs. But so varicose veins. The other thing is, since they're below the level of the skin, you can see where they're elevated, but you're not seeing the vein itself. The vein is below the skin, and you typically are not seeing
the rise in a lump in the skin.
Yeah. And they're, the size of a typical varicose vein is probably, several centimeters. Or I'm sorry, several millimeters. That's it's a pretty good size. When when they become full of blood and pressurized, they can become quite large. So spider veins, on the other hand, are small. Most spider veins are certainly much less than 1 millimeter in diameter. They're very superficial. They're not elevated. They reside anatomically. They reside in the skin.
Mm-hmm.
So, where varicose veins we can actually extract, doing something called microphlebectomy, we can take them out.
Take it out of there. Yeah.
Spider veins you can't take out because it would require you taking off the skin.
Now I get it. That's why I've had the treatments that I've had just make it disappear.
Right.
Yeah.
Exactly.
It doesn't leave. It's still there, but you can't see it anymore.
Yeah. And a lot of folks will come in, and when we're deciding, what kind of procedure we're going to do on what type of vein it is that we're dealing with, a lot of people feel like, well, just, take out the spider veins the same way you're taking out the varicose veins, and, it's just not possible. So you're absolutely right. We inject spider veins as opposed to taking them out. The spider veins in general have a little more color associated with them. They're either red or blue. Some are purple, but a variety of different colors, as opposed to, again, varicose veins, where you're not really seeing a lot of color. You're just seeing the elevation of the vein itself. Whereas varicose veins are usually associated with venous insufficiency or functional problems of the veins. Spider veins may or may not. Sometimes they are, sometimes they're not. Sometimes people just have sporadic spider veins, and the rest of their venous system is perfectly normal.
Yeah, that's another thing that I find pretty fascinating. Your body is a very complex thing, and you start taking a look at these things, and there's a lot going on. One thing that I thought of earlier, and I thought, okay, well, if your varicose vein is no longer functioning as anything other than a varicose vein, why would it have symptoms? Why would it hurt? If there's not stuff flowing through it anymore, why does it become a problem? And I'm just guessing because your body is not comfortable having that there.
Well, there is blood in varicose veins that's moving, either one way or the other. But that's why people have symptoms from varicose veins, because those veins are dilated, they're full of blood, they're pressurized. And that's what causes the symptoms.
Are they more likely to clot than a non-varicose vein?
Because often the blood flow in those veins is fairly slow.
Sure,
It becomes static, and that's when a blood clot forms. But when I say there's no real functional quality to a varicose vein, I didn't mean that there's no blood flow. There is flow, but it's not really functioning. Doing any additional, movement of blood in the right direction, basically, is what that is.
Yeah, it's interesting. By the way, gang, it's if at any time you make these little notes, these little mental notes, call the office. Go to veinclinicsofhawaii.com, because I think that you actually, it's like a gold rush. When people find out a bunch of really good information all at once, they want to grab that pen and go prospecting. They want to find out what's going on in there. And that's what I think that we're doing. In many respects, we're waking people up by doing the show, letting everybody know that, hey, you have these things, you're among the group that we're sorry you got them, but not woe is me. We can fix them.
Yeah. Well, and that's the thing to keep in mind, because, they're not only are they fixable, but they're pretty easily fixable these days with all the new technology that we have. And then the other question about spider veins is, can they be on other areas of our body other than just our legs, as opposed to varicose veins, where typically they are on, superficially, they're on primarily our legs. But spider veins can be all over our body. And we treat spider veins, we treat a lot of people, there's the spider veins on their face.
I was going to ask you that. I don't want to use the word, I'm using this lovingly, but everybody has a drunken uncle somewhere in the family.
Right.
And old Uncle Bobo, look at all those things on his face, all those veins.
Right.
And I'm guessing that if you abuse yourself pretty well, you're going to get some of these things.
Yeah, well, in that situation, yes. But more importantly, sometimes you don't have to, abuse yourself. You're still going to get them. And so...
are they treated in a similar fashion?
They are. Yeah, they're treated in a similar fashion. And, we see them around the nose. We see a lot of dilated veins on the forehead.
That's what I say, the forehead. I've
seen. And we inject those all the time. We see veins kind of around the area of the eyebrow. We see cheek veins, and actually we can do a pretty good job getting rid of those, again, with injection sclerotherapy. So the other kind of vein that we wanted to talk about today are reticular veins, and I think that a lot of people haven't heard of that type of vein before. Most people have heard of varicose veins. Most people have heard of spider veins, but reticular veins are not, a term that is commonly used. But reticular veins are sort of an intermediary vein between spider veins and veins that are deeper in our leg, either, varicose veins or the superficial venous system just in general. So what does a reticular vein look like? And again, the reticular vein, where does it reside? It is also in the skin, but it's in the deepest level of the skin.
Okay.
So, sometimes you're going to see it, sometimes you don't. The venous system in general, it's like a big tree root, and there's, various generations or various levels of the size of that root that go back then into the trunk of the tree. So, the trunk is sort of the main vein that goes up, from our legs or through the middle of our body. But, the ultimate, the very periphery of that, root system are tiny little roots, and those are the spider veins. They're the most peripheral. But the important thing is that even though they're small, they're connected with the venous system in general, and if there's a problem in one area, it often is transmitted to another, and that's why sometimes spider veins are related to poor vein function otherwise, but again, sometimes it just happens.
Yeah, and there's one thing that I'd heard in the past, maybe I'm wrong, or maybe I heard it the wrong way, is I thought reticular veins were, rather than up and down, they were more sideways.
They are.
And so that maybe when they have a problem, it's either easier or harder to detect, depending on where that is. In other words, don't you sometimes have a reticular vein that's in between two others? That's connecting two others?
You may be confusing reticular with perforator veins.
Oh, maybe it's perforate. Yeah,
perforator veins are short veins that connect the superficial system with the deep system. Reticular veins are pretty superficial.
Okay, gang, this is exactly why you don't want to book me for the surgery, because I can make these mistakes. Could be a pretty big one. So you're right. I was swapping the terms up, but but what you said so far, though, even led me to believe that I was somewhat on the right path, because they didn't look like they were the majority of veins; that they were the minority of veins.
Yeah, they are. But the reticular vein, we often refer to a reticular vein as a feeder vein into a spider vein complex.
Gotcha. Okay.
So that's often the case. So it's a feeder vein. It's a little deeper. So it's, kind of bringing blood up into the more superficial level where the spider veins are. But it can also be abnormal. And we treat it in a similar sort of fashion. The reticular veins are, again, not so superficial. Sometimes we can see them with the naked eye. Sometimes you can't. But typically they're always bluish in color. They're a little bigger than spider veins. And again, when we're treating spider veins, we're always looking for the reticular vein level that is feeding into those spider veins.
But what you're saying typically too is the treatment for reticular vein is like spider veins. You do
it is
same sclerotherapy.
Same thing. Yeah.
Okay.
So sometimes we can see it, sometimes we can't. When we can't see it with the naked eye, we use something called a vein light. And a vein light is it's more of it's basically just a light. It's within a metallic kind of ring.
Yeah.
And
they're fascinating, by the way.
Yeah. There's the middle is free. There's nothing in the middle. So basically, what that light does is that it shines light into the skin. And we can basically it transilluminates the vein that is below it.
It's fascinating to be able to see that.
Yeah. And so we use that vein light to not only diagnose or to identify reticular veins, but also treat it we often use that vein light to show the vein and then inject it while we're looking at it.
Just out of curiosity, let's say that you've got one of those on your shoulder. Okay, and you look, it's like a loop, right? You look through it and you can actually see into your skin.
You can.
Now, when you're going to put the sclerotherapy in there, is it right there where that device is?
Yeah.
Yeah, because it's right above, the hole's right underneath where the light is.
Right. Yeah. There's nothing in the middle of this light, so that we can use a needle and a syringe and inject into that vein. So that's how we look at that. Spider veins and reticular veins, do they cause symptoms? And, again, that's an easy question for insurance companies. They say no. But just in my experience, many people come in and they say they have symptoms, and often we treat them and the symptoms go away. So I saw a lady here recently, a 54-year-old lady, who was pretty healthy. She wasn't on medications. She had no major surgery. She had not been treated for vein disease in the past. She was a nurse. So, this is another person who, again, is on their feet a lot. So just by virtue of that, she's at a little higher risk of having some form of venous insufficiency or venous disease. Her mother had vein disease. Gotcha. She didn't really remember exactly, what form. Was it varicose veins or other things? But there was a family history. And this patient had 3 children, so she kind of had the trifecta.
I should say
of risk.
What didn't she have? I mean, it sounded like she had just about everything.
Well, she had the main 3: genetics, being a woman, being having had several children, and then also having a job where she worked on her feet. And she came in and described to us symptoms that were in keeping with venous insufficiency. She had achiness, heaviness, and a throbbing sensation in the areas of her spider veins. So again, sometimes it's hard to sort that all out. But she was identifying those symptoms in those areas. She had a little bit of ankle swelling in the past, although that was sort of a minor part of the whole story. She said that she elevated her legs at the end of the day. She'd work for 12 hours in the hospital, come home, elevate her legs, and that made her legs feel better.
That's truly amazing. Every time we do the show, gang, this comes up a little bit, and you'd be surprised how much of this is instinctive. Our bodies tell us, maybe when you're thirsty, you want something to drink, and when Mama needs to put her legs up, that's it.
Yeah.
She's going to go because her body is saying it's legs up time.
Yeah.
Not later, now.
Yeah. Well, that's true. I mean, there is, elevating your legs. If you have vein problems, it is sort of instinctual. Yeah. You just kind of learn that, at the end of the day, you go home and how good that feels. So you keep doing it. But she told us that. She also said that, her legs feel okay in the morning, but as the day goes on, as the workday goes on, her symptoms get worse and worse. So those 2 things right there are kind of hallmarks for venous insufficiency, elevating your legs and getting relief from that. And then also, symptoms worse as the day goes on.
Okay.
So again, you have to be very suspicious of the fact that there's venous insufficiency, and we should look into it.
One of the things that I looked at, I saw this was pretty interesting stuff, is that I guess that once you've seen as many patients, as you have, and how many people your offices handle. There are no surprises. However, that most of the individuals are not aware of that. I think a lot of us think that we're the only one with this problem. How come I got spider veins on both my knees? I've never seen anybody else with them on their knees. How come I got them?
Yeah. We hear that a lot. And also, we hear, gee, I'm the only one in my family who has this. I've got 3 sisters. They all have perfect legs. And, my mother.
Woe is me.
So, So anyway, she had tried compression stockings in the past. However, never really used them consistently, nor did she use them at work, which was probably
where the most important is. For
me.
That's
the most important time. When I talk to people about using compression, most of the time I say, hey, listen, if you can wear your compression stockings just during the workday, take the weekends off or whatever. That will give you not only good relief of your symptoms while you're at work, but will also give you an idea as to whether your symptoms are due to vein disease, because stockings will reverse those symptoms most of the time.
Okay, now speaking about that, gang, if you're contemplating using the stockings, which I highly recommend because I do, and I'm very angry right now because I'm suffering through another little issue where I have some temporary nerve damage that I'm dealing with, and it's very, very difficult to put the socks on. And yet I know, well, how difficult can it be? Because the reward for putting them on far outweighs the difficulty of putting them on. But if it's 3:30 in the morning and you're telling yourself when it won't go on, you think, can I do something instead? In other words, and so what I'm getting at is once people find out the benefit of this, then doesn't it become like, I got to go put my legs up? First thing in the morning is when it's easy to get those socks on. Yeah. Right? Because you haven't been on your feet.
Right.
So you're not all swollen up.
Yeah, exactly. Yeah, and that's the other thing we tell people all the time. That's when it's time to put on the stockings, is after you've been laying flat all night, and hopefully most of that swelling has gone away.
What happens if you inadvertently, this happened to me a long time ago, I forgot to ask you about it. Came home late, turned on the television, was waiting to see the news, and I fell asleep. And I had my socks on all night. And in the morning, when I woke up, I thought, okay, now I've had them on all night, and I'm going to take a shower, and I guess put them back on. Are my legs going to know? And I didn't. I took them off, I took a shower, and I just got out of there. Yeah. But is that a problem if you do?
If you wear them all night long?
Yeah.
No, it's not. Yeah. No, it's not. It's not when you're flat in bed, you're not gaining the advantage of having compression stockings on, because you don't need them at that moment. But it's not going to hurt you. It's not going to hurt you.
In my case, it was elevated. Mm-hmm. So it's even less that it's going to help me, right? Because you're already elevated.
Yeah, if your legs are elevated, even less. So.
But the good news was, I thought, wow, that's great. Look at that. I have an ankle. I mean, sometimes, isn't that sort of interesting? Have you noticed that? And I know that there are people that are listening that you don't think you have an ankle. You do. It's there. Mm-hmm. It's just that you've, for so long, you've been, I don't want to say abusing it, but you haven't been getting treated. And you'd be amazed at how fast that can be reversed if you do the right thing. If you wear the socks and be a little smarter.
Yeah. And it doesn't take a lot of edema or a lot of swelling to hide your ankle. A lot of people have that problem. They come in, they say, "Gee, I haven't seen my ankles for years." But all those things will help. Yeah. So when we examined this lady, she had spider veins, and her more symptomatic area was kind of what you described on yourself before. The upper outer part of the thighs. There was a pretty good size spider vein complex on both sides. Yeah. And that's a common sight that we see for spider veins. Spider veins can be scattered all over, but the upper outer part of the thigh is a pretty common place for people to have spider vein complexes.
Kind of, isn't that sort of interesting, Doc? Because that muscle is so huge that obviously these veins are on top of the muscle and under the skin. Or, in other words, any other vein on that part of your leg, you're not going to see it. Mm-hmm. There's too much muscle covering it up, sticking down way down in there.
Well, again, the spider veins are right in the skin, so they're superficial to everything, but fairly easy to see most of the time. But so she also had spider vein complexes on the outside of both knees. And those are the two areas that she complained about with respect to her symptoms. Now, she had scattered spider veins elsewhere, but she pointed those two areas out specifically. When we looked at her, we were also evaluating the presence of reticular veins, and she had reticular veins. We were looking at her veins with the vein light, and you could see the reticular veins again that were feeding into those spider vein complexes. Sure. And again, more symptoms in the upper outer thigh, but they were sort of concentrated in the area where the spider veins were. In addition to the spider veins, she had some dilated veins, more varicose in nature, although not huge varicose veins, that were starting to show up on the upper part of the posterior calf.
Is that kind of typical? Is that the intermediary between spider veins and varicose veins? So they're not really varicose veins, or are they?
Well, reticular veins, you're right. I think some reticular veins can dilate to the point where they do become, they do start to look like varicose veins.
Yeah, that's what I thought.
Now, most varicose veins are anatomically a little deeper under the skin, but reticular veins, when they get big, can become dilated. And she did have that type of vein on the back of the calf, and she appeared to have some symptoms in that area too. So we did an ultrasound, and which is what we typically do, and the deep venous system was fine. We didn't see any blood clots or anything wrong functionally with the deep venous system. Looked at the superficial venous system, looking for what we call axial reflux, venous reflux within the saphenous veins, and she did not have that either. So here's a lady with, spider veins, reticular veins. They appear to be symptomatic, but she does not have underlying venous insufficiency. So
that's very interesting.
Yeah. In that this she's probably not. This scenario is more uncommon than most other scenarios, but still, this is a population of people who, unfortunately, insurance doesn't really accommodate. Yeah. But I believe in a few patients like this, they really are having symptoms, and it's related to their veins, to their spider veins and reticular veins.
Is it your hope that the profession is able to talk back and forth with the insurance company to a point where they reevaluate at what level they're going to start accepting claims for either discomfort, lack of the ability to go to work, perform regular functions? Maybe they just got to say, hey, unfortunately, more and more people are affected by this, and it's got to be, we got to figure out a way to cover them.
Yeah. I don't think that's going to happen.
You're right. There's not departments of people getting together at most of these companies saying, how can we give away more of our money?
Yeah. Well, I think, would there be a group of people who would try to make the case for that if we thought that it was going to make any difference? Yeah, sure. Yeah. But the symptoms, those few people that we see with spider veins that might be symptomatic, the symptoms are not great. It's not like long-standing chronic venous insufficiency. So it's a little hard, even from that standpoint, to kind of make the case for, gee, this is something that really should be covered by insurance. So I just don't see that changing.
Yeah. And by the way, VeinClinicsOfHawaii.com is where you go land to get further expansion on some of these things. But I think that maybe a big part of what you do sounds to me like is having a patient being able to specifically identify where the symptoms are and what they are. Because remember you said before, some people think it burns, some people think it throbs, some people think it's heavy. It's the same condition. It's just that we all perceive it a little bit differently. We
define it a little differently.
Yeah.
I think, people, they need to not only be able to define, but also to recognize, kind of going back to, all the things that people are able to ignore, just being able to recognize when they are having symptoms and, be honest with yourself and say, gee, maybe this is due to something that can be corrected, because often it can. And why not? Because it's going to improve your quality of life. So the what did we do initially? Well, the initial line of treatment for this lady was to get her into stockings that she was going to be a little more consistent in wearing. And so we got her into a moderate compression. It was 20 to 30 millimeter mercury compression. Sometimes we go 30 to 40, but
is that kind of the max, 30 to 40?
No, there's actually even stockings that are tighter than that. But for most practical use, 30 to 40 is as high as we go. But the higher you go, the more difficult they are to put on.
Sure.
And the less likely it's going to be that somebody's going to use them consistently. So and then the next question is, should you go with a thigh high versus a knee high stocking? And again, the thigh high stocking is probably a little better option with respect to what it's doing for you from a functional standpoint, but it's people are less compliant. Especially
I do have to ask a question about that, because that's kind of where I would be a candidate. But I do know that anything over the top of my lower upper knee area, it digs in too much.
Yeah.
In other words, so obviously you need a different garment for that, right?
Right.
Which would be a thigh high.
Yeah, actually, you're right. Some people do complain more about knee high because it kind of digs into the back of the knee, and there is that rare patient. This is I'm more comfortable in my thigh high stockings.
But I must tell you, one time I had on my regular knee highs, and I guess that it was painful, so I peeled them back a little bit, and I forgot. I went about my business, and then all of a sudden my leg really started to hurt, because when you go one layer over another layer, you're doubling.
Yeah.
And I didn't know that, and it was really digging in.
Yeah.
And I thought to myself, boy, can this be a problem? I'm sure you've seen this sometime where somebody has either so much edema or that thing is so tight that it looks like they've strangled their leg.
Yeah. That happens. That happens. And, with when people are uncomfortable with that stocking behind their knee, I will often tell them to fold it down, just like you did, and try to get it into a position that's comfortable. For you, it didn't work. I know, when I'm at work, I wear compression stockings.
Sure.
I wear knee-high compression.
Yeah.
Because it makes my legs feel so much better by the end of the day.
Plus, you got to convince patients like me why to wear them. So you wear them like this.
Yeah, exactly.
Okay.
So now, there's various, manufacturers and various models, styles, etc. And some of them are too long. Some of them, hit the calf at just the right point. But I often I have a couple pair that I need to fold down. And so I guess you just have to kind of play with it and get it to the point where it's comfortable for you. I think most people can find that level where it's not.
I'm thinking, because I don't want to say this is a new concept, but for many people that turn on to it and start doing it, they realize, gee, I wish I'd been doing this, longer.
Oh, yeah.
I would imagine also that, these things they've actually come down a little bit in price, I guess, because there's some competition. But it would seem to me that there's going to be even more reasons down the road for people to be able to get them custom made, because we are all a little bit different.
Yeah, everybody's a little different. They've got luckily the manufacturers of the of compression stockings have quite a few different sizes to pick from.
Yeah.
But sometimes we do have to get them custom made. But unfortunately that does require more expense. But so in addition to compression, we started an anti-inflammatory. These are the usual conservative ways to treat venous insufficiency and the things that come along with it. Typically, we like to give people on either Aleve or Advil some form of a non-steroidal anti-inflammatory, and then elevate their legs when possible. Try to get that into people's routine. And then avoid prolonged, standing and sitting. But unfortunately, for most people, when they're working 10 or 12 hours a day,
that's a pretty hard deal.
It's hard to do that. Yeah, although that's another thing that the insurance companies want us to do is to instruct our patient not to.
Well, I think though you can invent ways around you to be able to take a little deal here, a little deal there. I mean, for instance, if you're in a job where you do get breaks, you can find somewhere sometimes to at least get your feet level with your heart or something, even if it's for a little while, because you've told me, and we've said this on the program many times, doing nothing is doing a little bit of something is way better than doing nothing.
Oh, yeah. Yeah, I mean, where there's a will, there's a way. Yeah. And I think if people find or recognize the benefit of doing those things, then it doesn't, it kind of doesn't make the process as bad as it would otherwise be.
So this gal's working on it. I mean,
she is.
Yeah. So she got work.
She did. Yeah. She was consistent in her treatment. She did that for several months. Came back. She had actually opted for thigh-high stockings, so she was going to work every day with thigh-high stockings. And was fairly consistent. She'd miss a day here and there, but for the most part, she was wearing them.
Those are mostly fashion-oriented days, I would imagine.
Yeah. And she felt like she had some relief of her symptoms from the stockings, but not completely. And when she removed the stockings, the symptoms came back.
Almost like an incoming tide. I mean, it doesn't take long. Yeah.
Right. Yeah. We hear that from people. Yeah. Some people say, gee, at the end of the day, I take off my stockings and I just literally feel a rush of, tingling or whatever achiness kind of going down back into your leg. And it's hard not to kind of relate that to
I've actually had a way to postpone it a little bit. And that is when you do decide to go down is take the socks off and then elevate for just a while. Mm-hmm. And so it doesn't rush back in.
Yeah.
Gets in there back slower.
Yeah.
And I think the main thing that almost everybody wants out of that, and if you're like me, sleep is very important. And a lot of these symptoms actually impact your ability to either fall asleep or stay asleep. We've talked about leg cramps and other things, which we can mention briefly. Mm-hmm. But mainly, if you are religious about wearing the socks and religious about elevating a little bit, they'll be easier to put on in the morning, easier to wear all day, and easier to take off at night, and not feel like, gee, 5 minutes ago I took my socks off, and now look, my legs are all swollen there right now.
Mm-hmm. Right. Yeah, you have to get into kind of a schedule or a routine and try to stick to it. So, but we, so again, this is one of those ladies that she had symptoms that were very consistent with the process of venous insufficiency, although we were not able to document reflux,
for her
blood going in the wrong direction in her superficial venous system. But at the same time, she was, relieved by conservative measures, and her symptoms were very in keeping with somebody with venous insufficiency. Now, I will say one thing that, sometimes the ultrasound study is something that is not, it's not a definite picture in time every time. You're going to see the same thing. It's not like a photograph. It's not like even a chest X-ray where it's a static photo and it's going to look, the same way today as it's probably going to look in a week from now. The ultrasound is very not only operator dependent, although we don't have that problem. I think
you got good operators. That's
but depending on whether the patient is well hydrated or did they come into the office and they got real cold? A lot of these types of things can impact how sensitive the ultrasound will be. So, but we do the ultrasound and we go on whatever we find. So maybe does she have some subclinical reflux that's there that we just didn't pick up that day on ultrasound? Well, maybe, but this is somebody that we're going to follow over a long period of time, so that if it at some point, if it's important, if it's significant, at some point it will kind of resurface and we'll be able to see it.
As I look through what you're doing with this gal, it seems like she has been very cooperative and participatory. In other words, what was it, David Horowitz? Remember the guy who used to say, "I'm mad as hell and I'm not going to do something about it."
Yeah.
In many respects, having that sort of an attitude as a patient must be great for the for the doctor to know, this person's swinging with us,
Right, right. I mean, a lot as far as how we're going to, eventually treat that patient is very, very dependent on, the patient's interest for getting treated and their commitment to the process. Yeah, definitely. It makes it much easier.
So, before we put a cap on the day, where is she now, and what does she and you expect going forward?
Well, we decided, we gave her the option of treatment. Mm-hmm. So, what were the potential, treatment modalities that we could offer her? Well, of course, injection sclerotherapy was going to be part of it. And we were going to inject, reticular veins. As it turned out, we did her spider veins also. Mm-hmm. But she had those dilated veins on the back of her calf. And I really felt like that was probably part of her symptom complex also. So we did what's called microphlebectomy of the dilated veins on her calf. And, when we do that, we just make little needle puncture sites along the course of the vein. And we've got special instruments that we're able to extract those veins. Mm-hmm. Those are very, very superficial. And then we did injections of the reticular veins. Again, some we did just visually. Some we used the vein light. And then, like I said, as it turned out, we also, at a later date, did her spider veins to kind of complete the job. Since we were doing microphlebectomy, and injection of reticular veins, that's something that the insurance companies do cover.
Yeah. That was my next question. I'm assuming that the insurance companies are a little bit more simpatico with that.
Right, they are. Yeah. So we were able to get most of her stuff covered by insurance. A little bit of it was out of pocket, but she was happy to do that because of the cosmetic issue. Most importantly, doing those things resolved most of her symptoms.
Wow.
So it was good to see that we felt, although she was in sort of a gray area, we kind of decided that it was a medically related issue. We treated it, and her symptoms responded nicely.
Yeah, and I'm just assuming with that came good feelings and a feeling of relief and accomplishment.
Yeah.
And maybe, which was the goal outside, not just cosmetically, but functionally able to not concern herself with symptoms because they were being handled a little bit better.
Right.
Yeah, that's
sure.
Great.
Absolutely.
Okay, so that means, and by the way, if you could say, well, that's you, that's me. Or you could say, well, that sounds like my wife or my daughter or my grandpa. I think that this is what you've been talking about with regards to this lady. That could be anybody. That male, female, young, old.
Absolutely.
That was a pretty interesting one.
Absolutely.
And so, just as a real quickie, in the few seconds that we have left, a minute we have left, I would imagine that the frequency of which she would need to be re-examined or treated would be decreasing because of the amount of work that's been done. But isn't it a commitment that needs to be made to continually follow up to prevent it from backsliding into the way it was?
Yeah, I think, most people, if they are, committed to managing, their vein disease, their vein problems, because, since most venous insufficiency is genetic, it's not like we're changing their likelihood of having further problems. So the best thing is to do periodic surveillance. Usually we like to do an ultrasound about every year, or if they have new symptoms, and just keep track of the state of their vein function and do things earlier than later.
Yeah, and that's the key, gang, and that's mainly why we do the program. Now, if you'd like to experience how this flow chart could work for you, I'd suggest that you go to www.veinclinicsofhawaii.com and check it out. There's a lot of other really neat things on the website, by the way. You want to talk about, spider veins and being cosmetic. There's a few other cosmetic things that are really fun. And not only are they fun, but when you talk about self-esteem and boosting that, it's really evident when you look better to yourself, you feel better about the things that you do. So we hope you've learned a little something today. And please come back again and see us next week. In the meantime, if you want to know more, please do what I ask. go to veinclinicsofhawaii.com. That's www.veinclinicsofhawaii.com. And get on it. Get on it and make yourself feel a lot better. You're going to feel a lot better for it, and you'll be so glad you did. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.